All right. So we're going to begin our first lecture, which will be an introduction to cancer. If I am going too quickly, too slowly, stop and let me know. And if you have any questions throughout, also please raise your hand and let me know. So by the end of this session, these are all of the things we hope you will have learned. So there's a lot of important content we'll review in this lecture. So we're going to describe the growth and development of cancer cells. We'll describe the distribution of cancer, or epidemiology around the world of cancer. We'll discuss various risk factors for cancer. We'll describe strategies for preventing cancer. Hopefully we'll also review cancer prognosis and how prognosis relates to diagnosis and relates to staging. We'll describe the various types and goals of therapy. We'll describe key differences between adult and pediatric cancers. And then finally, we'll review the key differences between solid cancers and liquid cancers. Okay. So before we talk about the development of cancer, we're going to go back to biology class and talk about the development of normal cells, okay? So in this example here, we have a skin cell. So you can see on the bottom, we have the dermis, and then in the basal layer, we have dividing cells. And then above the basal layer is the epidermis, okay? And then these cells up here represent dead cells that are shed from the outer surface. So this process of cells dividing in the basal layer, creating the epidermis, and then those dead cells being shed from the outer surface, this is constantly happening in each of our skin cells in our body, okay? And so the term apoptosis is important to remember. That is the step where these old or damaged cells above the epidermis die off, okay? And then the proliferation is what's happening down here. That's the growth and the reproduction of new cells, okay? So the rates of new cell growth and old cell growth, so apoptosis and proliferation, are balanced during normal cell development, okay? And this is happening in all of our cells in our body in different rates, depending on what cells they are. But this balance of apoptosis and proliferation is what contributes to normal cell development. Any questions about this? I know we've all had plenty of biology classes here, so this should be review. Okay, so another important concept to understand as we move on to discussing cancer is the normal cell cycle. Does everyone remember this diagram again from biology? Yes. So all of our cells in our body are going through this process, all of these steps. So G0 is the resting phase of a cell. So nothing is happening here. The cells are just hanging out, not doing anything, just resting. G1 is a growth phase. Synthesis, or S, this is where the copying of DNA occurs, okay? And then G2 is another growth phase. And then M, mitosis, is finally where this one cell divides into two, okay? So in S, we have, so if we start with one cell with one copy of DNA, that cell moves into synthesis, then we have two copies of DNA, and then during mitosis, those two copies divide, and then we have two identical cells, okay? All right. So now moving on from the normal process of the cell cycle, cell division, we're going to move on to talking about what happens for cancer to develop. So I want you all to turn to your neighbor and just take a minute or two and try to discuss together what you think might be happening in this photo here. Okay, so just turn to the person beside you and just talk about what you think might be happening here. Take one more minute. Okay. So what do we think is happening in this photo? I saw a lot of discussion from the bone tate in front. What do you think is happening in this image?
What we discussing is what we think is between the what we think is
Mm-hmm.
what is so it can really come whatever that we discuss like really I can see the weakness from some
Mm-hmm.
and I might see the review I might call it between
Mm-hmm.
so but in this lesson the presentation what we can see is that those cells in the presentation are different from the cell to the fourth situation.
Mm-hmm.
So like this new structure is the best cells.
Mm-hmm.
So I skip the second and presentation because exactly what is the thing. So the cells is leading from the normal cell that was in the best normal cell or the cell code.
Mm-hmm.
So on the last picture is an uncontrolled growth. Mainly it's about that cell, the first cell, the division was to take only 2 hours. On the last picture, says uncontrolled growth.
Mm-hmm.
The cell is no longer taking the normal 2 hours that was supposed to take for
Mm-hmm.
it is maybe taking 30 minutes. It is now growing abnormal.
Mm-hmm.
And it is no longer keeping the same structure as the initial normal side.
Yeah, good. Great. Yes, that's a good explanation. Um, so yeah, so this image is showing, as Ntate described, this image is showing what happens when a cell develops abnormally and then continues to divide in an uncontrolled manner. Okay. So usually in a normal cell, if there is any damage to that cell, There are checks and balances in our body that will say, this is not normal. This is a damaged cell. This cell needs to die off. But sometimes those checks and balances stop working and the body doesn't detect that there is that damage to that cell. And then when that damaged cell does not die off as it should, and instead continues to divide in an uncontrolled manner, that is cancer. Okay, so you can see here there's a mutation. There's just one mutation in these cells up here. The body doesn't detect that there is a mutation. There's an abnormality, allows for those cells to continue going through that cell cycle, okay? And then it develops a second mutation. The body still doesn't detect that there's something wrong happening, and then continues to go through that cell cycle, creates a third mutation, and then again, body still doesn't detect that there's something abnormal going on, develops a fourth or a fifth or a sixth mutation, okay? And then all of those checks and balances are off, and that normal process of apoptosis and proliferation, so growth and dying off, is no longer happening. And then we have this uncontrolled growth of these abnormal cells. And we can see that these cells are still somehow similar to these initial normal cells that we have up here. But there are additional abnormalities. And so those abnormal cells continue to grow and divide, and that is cancer. And there's so many types of cancer, as we'll discuss over the next few days. But this is what's happening in all of those different types of cancer, okay? This abnormal, uncontrolled growth of cells. Any questions about this? Yes.
I like abnormal of every other cell. Itself normal cell.
So the cell starts off normal and then develops some abnormality. And then sometimes those cells will die off and then cancer won't develop. But if the body doesn't detect that there's an abnormality, and then it continues to allow that abnormal cell to divide and grow, then that's what develops. Great. Okay, so now we have now we understand the process of the development of cancer cells, and now we're going to move on to a new concept that's described in these that's shown in these photos here. So again, I want you to turn to your neighbor and think about what might be happening in these photos here. Okay, so again, this is starting off here. This is our normal skin cell that we showed at the beginning of the lecture. So we have our dermis, our epidermis, and then this is what we discussed on the last slide. So we have the uncontrolled growth of abnormal cells in the epidermis. And then you can see there's step 3, 4, 5, and 6. So what do we think is happening here? Turn to your neighbor and discuss what you think might be happening.
Your question. And sorry, I had when you like you mentioned before, you have remember like they detected like everyday dollars. Minimal, and then we have just being negative off that. But then we have been just taking one cell to have little for the other to not detect it for it to become like a tumor.
Yeah.
Well, I remember seeing that one time is my like, oh wow, so like the cancer is so like that. Like it doesn't mean it's like, oh, it's like overdose.
Yeah. Right. Yeah.
I usually are
MK.
the NKs, yeah, and macrophages had that, like those. I haven't given this lecture before, it's like the doctor, but I feel like that's like the like the valve. Yeah. But like I was learning about like this like the break. You know, The break would go.
the break, and yeah, like the MKs.
Yeah.
I feel like that would help.
Yeah. Yeah.
Yeah. Because like in the terms, like I'm
So,
on this.
yeah,
So like
that's
check out it.
That's true.
Not for all.
Alright.
Okay. Okay, let's take 30 more seconds, wrap up your discussion. All right, so what do we think is happening here in these images? Yes.
Yeah.
Yes. What was that right? What was the word you just said? No, you're right.
Metastasize.
Yes, metastasize, exactly. Yeah. You wanted to add something in topic?
I was just thinking, if she goes, well, I see that one of the species, wait for breast ligaments and kind of
Yeah. Exactly. Anyone else have anything to add? No. Good. Yeah, that's exactly right. So in the first image on the left, that's a normal, healthy skin cell. Okay. And so in that skin cell, maybe the patient had a burn, like a sunburn when they were 10, and there was some damage to that cell, right? But we have these normal cells. We have these cells in our body and natural killer cells and T cells that will detect that abnormality. And in that cell, those abnormal damaged cells will die off, right? but over time, maybe there's repeated damage, repeated sunburn, and those checks and balances, those natural killer cells, might allow some of those damaged cells to continue to divide and grow. And then that's what we see happening here in the second photo. And then in the third and fourth photo, we can see those abnormal damaged cells continue to grow and divide. Initially, they're just in the epidermis, but then they invade the basal layer. Then they continue to grow and divide. They invade the epidermis. They continue to grow and divide. And then they reach the bloodstream. And then what do we think happens when we reach the bloodstream with the normal cells? Then they can spread, move to other parts of the body. Okay. So what's happening in the sixth image here, that's what we call metastasis. Okay. So that those abnormal cancer cells, they have left the initial site of where the cancer originated, and they entered the bloodstream, or sometimes metastases can spread to the lymphatic system as well. So they might either enter the bloodstream or the lymphatic system, and then they can spread to other parts of the body. Yes.
This is tough question.
Mm-hmm.
Usually in this picture, let's say we have that those kids are ourselves, and then maybe let's say the once those still maybe some facility. Let's see that. So it happens that those kids are themselves sleeping or have been in that street. What happens to the okay. Instead of like a bona I abnormal relationship structure. If you up until that's true. So if Masolami have followed the detect the head, let's see the lapse of concentration for the muscular damage. But in the bloodstream, definitely the level divide themselves in. So why not can I this a technique that deviation from normal and then we counter around this?
The question is, why is it that after the doing metastasis, the cancer cells enter the bloodstream of the lymph, why is it that the white cell count, the white cells or the CGD, the ones that fight infection, why is it that they don't do this?
Okay. Yeah. Yeah, that's a good question. Because those cells, those immune cells, so the white blood cells, they're trained to detect bacteria, viruses, and this is different. Okay, these are cancer cells. So the immune system doesn't know, isn't trained to kill off these cells, because these cells, they don't look like a virus, they don't look like a bacteria. Okay. So it just that's why the immune system doesn't know that this is abnormal. So they're not trained to kill these cells. Pardon? Yeah.
How wonderful cells. Those are the ones that maybe cancer cells, but most of us, I think we have like lots of illnesses like HIV, and you know when you have HIV, the immune system is so suppressed that they are not able to recognize that this is a cancer cell.
Yeah. Also, I think
Yeah.
This is not an infection. It may be the result of an infection, but it's
Yeah.
not an infection.
Yeah, and we'll talk, I think like there is some relationship between infections and cancer, and we'll talk about that in some upcoming slides. So it might all come together when we review those slides. Yeah, in the back.
Or thinking about MHCT, this makes me think of MHCT. Maybe this is what happens, this is something more or less similar to what happens in MHCT. Not correctly, I'm under the basis, but which can be taken as to meaning that the table of China's size, that's really
Yeah. Yeah, and I think another thing that might be helpful is, yes, these cells are damaged and abnormal, but they still they still look somewhat similar to the original cells. So yes, there is damage, there is abnormalities, but they still do look somehow similar to a normal cell of the epidermis. Okay, so that's part of the way that the cancer cells evade the normal checks and balances in natural killer cells, is because, yes, there's damage, there is abnormality, but they still look somewhat similar to that cell where they originated. So it's not like a virus or bacteria that could develop in the epidermis that looks completely different than an epidermis cell. These cancer cells, originally, they were a normal epidermal cell. Okay. All right. Any other questions about this concept? Great. Okay. So, okay. So this shows, this now shows what's happening with metastases throughout the entire body. So you can see this is a patient with a melanoma. You can see the initial tumor developed here, on some skin cells of the arm. It left the bloodstream, and you can see now there are abnormal cells in the liver, and some traveling through the bloodstream and down here. Some cells have traveled up here to the CNS system. All right, so to summarize, what is cancer? So we have damaged cells that evade the normal checks and balances in our body. And then there's this abnormal growth of those cells that creates a tumor or a cancer. These cancer cells then can travel to other areas of the body, continue to grow and further metastasize in those parts of the body. And then as cancer cells grow and travel, patients begin to experience symptoms. Sometimes patients experience symptoms when the cancer cells are still localized to the original site where the cancer cell developed. Sometimes patients don't develop symptoms until those cancer cells have metastasized and spread to other parts of the body. And then this abnormal growth of cells happen because of some genetic alteration. All right. So that is the development of cancer. Now we're going to move on to talking about the global cancer burden. So these are statistics from 2020, so about 5 years ago now. So in that year, there were almost 10 million cancer deaths worldwide. And about almost 20 million new cases of cancer diagnosed in that year. And during that time period in 2020, 1 in 5 people, so both men and women, would develop cancer within their lifetime. Okay, so how many people in this room know somebody who has cancer? Or how many people in this room know somebody who has had cancer? Maybe currently, maybe previously. Raise your hand. One person. Okay. So most of you, not all of you. Okay. How many people in this room know somebody who has died from cancer? Yeah, so a lot of you. Okay. So this burden of cancer, as you all know very well, is really significant. And this burden, while already significant, is only growing. Okay. So our rates of infectious diseases like TB and HIV have been decreasing, but the rates of cancer are only increasing. This burden that is already really significant is only growing. So in 2050, it's anticipated that there will be over 35 million new cancer cases diagnosed, and that is a 77% increase from the 20 million that were diagnosed in 2022. And this increasing incidence is going to be most striking in low human development index countries, such as Lesotho. So the increased incidence is anticipated to be about 142% in countries with a low HDI. So globally, in all countries overall, the incidence will increase by 77%, but in countries with a low human development index, that incidence is going to increase by about 142%. Okay, so the impact is going to be felt all over the globe, but especially in countries like Lesotho. And additionally, the cases of cancer are going to increase, but also the deaths from cancer are also going to increase. So cancer mortality in low and medium HDI countries is projected to almost double in 2050. Great. And so this slide here just shows globally which cancers are most common. This is worldwide. So in 2020, the number 1 cancer, this shows the diagnoses per 100,000 people worldwide, was breast cancer, the most common. So it's about 50 patients per 50 in 100,000 people would be diagnosed with breast cancer. And then second most common is prostate. Then we have lung, colorectal cancer, cervical cancer, stomach or gastric cancer, liver, uterine cancer, ovary, and thyroid. Right. And then if we look at pediatric cancers, the distribution of pediatric cancers. So if we look in North America, Canada, the US, and Europe, what is the most common cancer in pediatric patients? Leukemia, yeah. And then the second most common is brain or nervous system cancers. And then some other liquid cancers like non-Hodgkin's lymphoma, Hodgkin's lymphoma are also more prevalent in pediatric patients. And then we can see in Africa, the distribution of pediatric cancers is a little bit different. So leukemia is still the most common cancer in pediatric patients, even in Africa. But you can see it only makes up about 16% of overall cancers compared to in North America and Europe, where it's about 32%. And then the second most common pediatric cancer in Africa is non-Hodgkin's lymphoma. Okay, and then we have kidney or nephroblastoma, or it's also called Wilms tumor is pretty common. Almost 13% of all cancers in pediatric patients, and then there's a variety of other cancers. Why do we think these differences in distribution exist between North America, Europe, and then Africa? Pardon? Genetics, okay. Yeah, can you elaborate a little more?
Yeah, I know that or maybe and also I think I just know that how we can help is but I was like, yes, others,
Yeah.
I think also that, and also maybe the food is supposed to make us, maybe I'm not sure because I think Americans are in the clearly be exposed to chemicals like that.
Yeah, okay. So difference in genetics, difference in exposure related to lifestyle. Good. Anything else? There's another really significant reason. No. Okay. We'll get to the answer in a few slides. I won't give the answer away quite yet. Okay, so we're going to move on to risk factors for cancer. Oops, I didn't mean to show that. Okay, so what are some risk factors that we know contribute to development of cancer?
Vaccines.
Toxins? Like what?
Like, I think infections, there are a lot of
In factories, yeah, okay. So like different chemicals, yeah, yeah. Diet, yeah, diet is good. You were gonna say diet, okay, yes. Okay, okay, you first, so we'll come back to you. Infection, can you give an example? Yeah, good. Maybe said lifestyle. What aspects of lifestyle? Mhm. Yeah, yeah. Anyone else? No, okay. Those are all great, great answers. So you guys listed some of these. So toxins was mentioned, infections, hormones also, hereditary factors, so genetics, radiation, age, and diet was also mentioned. So we'll talk in more detail about each of these on the coming slides. So toxins, so you mentioned chemicals. Can anyone think of any other toxins that might contribute to cancer? It's something on the weekend that most of us might consume, maybe some of us. Alcohol. Anything else? Smoking. Good. Yes. All right. So those are the top two toxins that contribute to cancer risk. So smoking and alcohol. Okay. And it's really the cumulative effect of these toxins. So if you have just one cigarette, if you had one cigarette 20 years ago, if you have like one drink a week, that your risk is not going to be as high as somebody who smokes 10 packs of cigarettes every week for 50 years, somebody who drinks 5 drinks every day for 20 years. Okay, so the accumulation of these toxins increases the risk. Infection, so this was mentioned, and somebody listed HIV as one infection that contributes to risk. Can anyone think of any other infections that increase risk of cancer? Yes,
HPV.
HPV, good. Any others? Good. Those are the top two, but there are a few more. So there are various viruses and bacteria that can cause cancer. So HPV, or I don't have HIV on this slide, but we'll get to it. HIV as well. So HPV increases the risk for cervical cancer, penile cancer, anal cancer, vaginal cancer, and then oropharyngeal cancer. Hepatitis B and hepatitis C increase the risk for liver cancer. And then Epstein-Barr virus increases the risk for Burkitt's lymphoma, which is a type of non-Hodgkin's lymphoma. And then H. pylori increases the risk for gastric cancer. And so HIV has a strong link to the following cancers. So HIV increases the risk for non-Hodgkin's lymphoma, Burkitt's lymphoma, cervical cancer, as well as Kaposi sarcoma. So HPV, as I mentioned on the last slide, it increases the risk for a variety of different types of cancer, but most significantly, it increases the risk for cervical cancer. And so women with HPV have a much higher risk for developing cervical cancer than women without HPV. And so the Gardasil vaccine, so there's a bunch of different types of HPV, more than 100 actually. The Gardasil vaccine, which is the most common vaccine that prevents HPV infection, protects against strains 6, 11, 16, and 18. And 16 and 18 cause about 70% of cervical cancers and precancerous cervical lesions. And then 6 and 11 cause 90% of genital warts. Okay, so if the population is protected against HPV strains 16 and 18, that's going to eliminate 70% of cervical cancers, okay? So the HPV vaccine is a really, really powerful tool to protect against cancer. Probably the most important tool for cervical cancer. So H. pylori, I mentioned, contributes to the risk of gastric cancer. So H. pylori can create ulcers, and then the damage from those ulcers over time can lead to the development of gastric cancer. All right, so after knowing this, after knowing these infections that increase the risk for various types of cancer, why, let's go back to this, the pediatric distribution. So why do we think this, just now, knowing what we know about infections and the risk for cancer, why do we think this distribution might be different depending on the region? What do we think? What infections are more common in Africa compared to North America, Europe? Yes. HIV, yeah. HIV, which contributes which is a risk factor for non-Hodgkin's lymphoma. Okay. Pardon? Cervical, yeah. Yeah. Okay, so this is why there's a significant difference. There's a lot. This is why non-Hodgkin's lymphoma is a lot more prevalent in Africa compared to North America, because HPV and then also and Epstein-Barr virus are a lot more common in Africa. So that contributes to the risk of developing non-Hodgkin's lymphoma. All right. So next is age. So age is actually the #1 risk factor for cancer, because the longer we live, the more time our cells have to develop mutations. Okay. And so this graph here shows the risk of cancer dependent on the age. So you can see the risk is quite low if you are an infant, less than 1, and then that risk just continues to increase and grow over time as we age. So this is the #1 risk factor. So the older we get, the more likely we are to develop cancer. And so this is another reason, if you think back to the slide that discussed the incidence of the burden of cancer, how the burden of cancer is going to be felt more significantly in low HDI countries. There's various reasons for that, but part of the reason is because in low HDI countries, the life expectancy is growing in those countries. So people are living longer in Lesotho than they used to. So that's one of the reasons why we are going to be seeing more, why we are going to be seeing that increasing burden in countries like Lesotho, because as the population lives longer, their risk of cancer, they have more time to develop those genetic alterations that contribute to cancer. All right, we're doing for time. Okay, so radiation is another risk factor. Radiation people can be exposed to radiation in multiple ways. One way is through UV radiation from the sun. Also ionizing radiation. So this is high energy ionizing radiation such as X-rays and gamma rays. Those also can contribute to the risk of developing cancer, and particularly leukemia. And again, this risk is a cumulative risk. So if you have just a handful of X-rays here and there throughout your life, you probably will be okay, and it's not probably most likely will not lead to cancer. But this is why people that work with ionizing radiation, people that work in radiation departments have to wear equipment to protect themselves, because if they had that exposure every day that they're working, then over time, that cumulative exposure to radiation would more significantly contribute to that risk of developing cancer. All right. So hereditary factors. So there are some genes that we know play a role in the development of cancers, and only about 5 to 10% of cancers are attributable to genetic mutations. One of the most common genetic mutations that contribute to cancer risk are the BRCA1 and BRCA2 genes. Has anyone heard of these genes before? Maybe some of you. If a patient has these genetic mutations, so BRCA1 and BRCA2, this increases their risk of breast and ovarian cancer if they're a woman. And in men with BRCA1 or BRCA2 genes, they have an increased risk of both breast cancer and prostate cancer. All right, hormones. So what hormones do we think contribute to cancer risk? Have any? No. All right, that's okay. So estrogen and progesterone can increase the risk of breast cancer, and then estrogen can increase the risk of endometrial cancer. So oral contraceptives might increase the risk of breast cancer. An early menarche, so an early period, is also associated with an increased risk of breast cancer. And then pregnancy and breastfeeding are associated with a decreased risk of breast cancer. So the reason for that is somebody who had an early period, over time, throughout their lifetime, they're going to have more periods, which means more exposure to estrogen and progesterone. So that is why there is some link between early periods and development of breast cancer. Similarly with OCPs, with oral contraceptives, more exposure to estrogen and progesterone is going to increase that risk. And then alternatively, pregnancy and while people are pregnant and breastfeeding, they have less exposure during those periods to estrogen and progesterone. So that is why there is a link between pregnancy and breastfeeding and a decreased risk of breast cancer. And then menopause hormone therapy with estrogen is associated with an increased risk of endometrial cancer. All right. So now that we know all of the risk factors for cancer, we can talk about prevention. So prevention can be summarized as any measure that can be taken to lower the risk of developing cancer. And we can divide preventative strategies into two groups. So primary prevention and secondary prevention. Primary prevention are strategies that we do before the cancer has developed. So an example of that is the HPV vaccine to prevent cervical cancer, okay? And then secondary prevention, these are measures that are taken after the disease has developed to minimize complications or the impact of disease. This includes early detection. So this is especially important with cervical cancer. So if we do VIA, and we'll talk more about this in an upcoming lecture about cervical cancer, in patients with early stage cervical cancer, they can be treated with minimally invasive procedures that prevent the cervical cancer from developing to the point where the patient would need chemotherapy, radiation. Okay. And why is prevention important? So between 30 to 50% of all cancer cases are preventable, okay? So adhering to these to prevention strategies can eliminate a lot of the burden of cancer. And prevention offers the most cost-effective long-term strategy for the control of cancer. So if we compare the cost of lifestyle modifications like diet, exercise, vaccinations, those are a lot less costly than administering chemotherapy, providing radiation to a patient, okay? So this, we're going to talk a lot about chemotherapy and other strategies, other measures to treat cancer, but really what's really important to focus on is preventing the cancer from happening before, so that patients don't need chemotherapy, they don't need radiation. And we're never going to eliminate all cancers because as only 30 to 50% of cancers are preventable. But that is a significant proportion of cancers, so we need to do what we can to prevent that 30 to 50% from occurring. So knowing what we know now about risk factors, what can we do to prevent cancer? What are some prevention strategies? What do we think? Yes, and then back. Yes.
What to use the school to use like locally?
Yeah.
If it's possible, yes, but
Yeah, exactly. Did you have anything? Were you gonna say what you wanna? Exactly, HPV vaccination. Good. Yeah. So vaccination, reducing exposure to toxins like smoking. So avoiding smoking, limiting alcohol, avoiding other cancer-causing chemicals, control of cancer-related infections, so vaccinations against hepatitis, against HPV, treatment. So if a patient has H. pylori, they should be treated so that they're less likely to develop those ulcers that are going to cause genetic alteration that could develop into cancers. And then early detection as well. Yes, in the back. Yes.
I think exposure, yeah. The rest of exercise, yes. I'm not seeing any evidence talking about this because we have to that are mostly sitting really. So what can we do to after this science? That's a book I would call what should be
Yeah. Are you thinking of like as healthcare providers, what you can do to prevent exposure to radiation in the hospital? Or patients?
I can say it because you know there's a when if you are going to take a person for X-ray, you know the what is they have to do things to the patient for so that this will make there. I would say they feel safe to
I would say as a healthcare provider. Is that what you're asking? Yeah. I mean, I don't know what the radiation department does here to prevent exposure. But yeah, that is not my area of expertise. Right. radiation therapy.
So, are we saying vision care to go on so that you that the next you can get exposed to that?
So during radiation therapy, the patient is in the room alone. Okay. And so the nurse, doctor, no tech, is not in the room during the exposure to radiation therapy. And it's not like when the patients leave the room, they're radioactive and you can't be exposed to radiation in that way. So as long as, the provider is not in the room while the radiation is being administered, then they're in the room.
Also, in radiation therapy, also in anything with radiation, the providers wear that clip where it detects how much radiation exposure they have. And I believe it's every year, they have to check how much they've been exposed. So if you work in radiotherapy, you have to wear that clip where it collects over time, like how much you've been exposed to radiation. So that's another way to tell how much you've been exposed.
Yeah, Andy? Yeah. Exactly. Yeah. So the radiation is confined to the room because of the way, the way the room is built, the walls are built.
Let's do this so that the answer on this one.
Yeah.
Maybe the other ones, where there's most of right? Technique.
Yeah.
So we get roots.
Yeah.
You
Exactly.
don't think
Yeah. Yes, me.
I just want to how
Yeah. Yeah. Do you want to? Yeah.
we have three levels of prevention. Is it primary, secondary, and tertiary? So primary would be the before exposure, and then the primary would be when you're exposed. So the tertiary would be during the exposure. So any detection comes at primary prevention. To say that if you detected anything that you treated well, was, you know, when we say cancer cure chances are higher at an earlier stage that at a more advanced stage. When Alison was projecting those cancer cells and their spreading, it becomes easier to cure before, right? By infections type of treatment.
And early detection is only relevant for certain types of cancer. So there are certain types of cancer that we are able to detect precancerous lesions. So a lesion that is not yet cancer but could develop into cancer. And so the early detection, if we detect that at that stage, then we're able to eliminate those abnormal cells before they develop into cancer. So we are able to do that with cervical cancer. So that's why there are cervical cancer early detection campaigns and clinics. And then with colorectal cancer, we're able to do that as well with scopes. They can detect precancerous lesions and eliminate those. So this isn't something we're able to do with all cancers, but with some we are. And in the upcoming days, as we talk about cancers, like specific cancers, we'll review more of that. Okay. How are we doing? We have a couple of more concepts to review. Okay, where were we? All right, so prognosis. So prognosis is an important concept in cancer care. What does prognosis mean? If you had to describe prognosis to a patient, how would you describe it? Good. Mhm. Yeah. Any other things? Yeah. Okay. Chances of recovering. Yeah. Good. Yeah. Yeah. So those are all pieces of the prognosis. So prognosis answers a variety of different questions. So it answers the questions of what are the patient's chances of survival without treatment? How can treatment improve the quality or the length of the patient's life? What kinds of treatment are appropriate? So this is why prognosis is important, because in order to make the best decision for what treatment is appropriate for patients, we need to understand their prognosis. And so the factors that influence a patient's prognosis is the cancer type and the stage. So the prognosis is different depending on the type of cancer. So some cancers are a lot more treatable. There's survival is a lot better for certain cancers compared to others, and then the stage as well. So a patient with a stage 1 cancer, their prognosis would be a lot better than a patient with a stage 4 cancer. And then we also need to consider the patient's age, the patient's general health. We'll talk a bit more about how we evaluate that in the upcoming slides, and then response to treatment as well. All right, so the first factors that we consider when we're thinking about prognosis are diagnosis and staging. So the diagnosis, this tells us that the patient has cancer and what type of cancer the patient has using pathology, okay? Because masses and tumors can develop for a variety of reasons. Sometimes a mass or a tumor might not be cancer, even if we think just looking at the patient that it is. And so it's critically important that if we suspect that a patient has cancer, that we take a biopsy of the suspected cancer, whether it's a tumor, a mass somewhere in the body. And then we send it to pathology for pathology to tell us, yes, this actually is a malignancy, or no, this is a benign mass or tumor. All right, and then the pathologist can also tell us exactly what type of cancer the patient has. All right, so another factor that we consider when we're thinking about diagnosis is the grade of the cancer. So cancer cells are graded on a scale from 1 to 4. And so a grade 1 or 2 cancer cell, we say that those are well differentiated. And what that means is that those cells look pretty similar to the normal cells. So if we go back to the example of a melanoma that develops in the epidermis. A grade 1 or a grade 2 melanoma is going to look more similar to a normal epidermal cell. Well-differentiated cancers, they grow more slowly typically and have a better prognosis. And then poorly differentiated cancer cells, those look very different under the microscope from a normal cell. And so that would be grade 3 or 4. So again, if we use the example of a melanoma that develops in the epidermis, those melanoma cells are going to look more different than a normal epidermal cell compared to a well-differentiated cancer. Poorly differentiated cancers, they grow more aggressively, more quickly. They might initially respond faster to chemotherapy or to radiation therapy, but overall, the prognosis for these patients is worse. Any questions about this? Does this make sense? Yeah. All right. So as I started to discuss on the previous slide, pathologic diagnosis is really critically important in cancer because many diseases can look like cancer or mimic cancer. And so we want to make sure that a patient does actually have cancer before we treat them. Cancer treatment is really challenging. Patients can develop a lot of side effects. They might be on treatment for up to years. And so we don't want to treat a patient for cancer without knowing, based on pathology, that it is cancer. Okay. All right. And so depending on the type of cancer, the biopsy might be taken in different ways. With solid tumors, the biopsy will be taken from the mass where the cancer, or the mass or the tumor where the cancer is suspected. If it's suspected that a patient has a liquid cancer like a leukemia, usually there will be a biopsy taken from the bone marrow, okay? But regardless of where the biopsy is taken, that specimen should be obtained by a doctor with the support of a nurse and then placed in formalin. And then that sample will be taken to the pathology lab, the pathology lab where the pathologist will look at those cells. And then based on what they see of those cells, they can tell us if it is cancer and what type of cancer it is. Any questions about this? No? Okay. All right. So staging. So now, if we know the patient does have cancer, that's step 1. We confirm that the patient does have cancer and what type of cancer it is. Step 2 is determining the stage of the cancer, okay? And so the stage tells us the extent and the severity of cancer in the body. So if we think back to that example of the melanoma that developed in the epidermis, that cancer initially was just confined to the epidermis, and then it started to invade the basal layer, started to invade the dermis, and then eventually spread into the bloodstream. Okay, so all of those photos in that diagram, that cancer was at a different stage. We saw the cancer go from a stage 1 to stage 2 to stage 3 to stage 4. Okay, so it's really important that we know how far the cancer has spread. All right. And we do this in a variety of ways, and it is different depending on the type of cancer. The most commonly, we use imaging to determine staging. So at a minimum for most patients, we want to do a chest x-ray, an abdominal ultrasound. Ideally, if we have access to it, we should be doing a CT scan of the chest, the abdomen, the pelvis, the brain, if possible. Those are typically the sites where patients develop metastases. Common for patients to develop metastases in the lungs, and the liver, and the brain. So we always want to check if the cancer has spread to those areas, and we can see if it has spread to those areas using ultrasound, X-ray, CT. Okay, so that's why you'll see the doctor order those exams after the diagnosis has been made. Blood tests also can help determine the stage, and we use different blood tests depending on the type of cancer. Lumbar puncture also can help us determine the stage if it's a liquid cancer, and then hormone receptors as well. And we'll give more specific examples of these as we discuss the different types of cancer. All right. And so we're trying to answer these 3 questions when we're determining the stage. So what is the size of the primary tumor? What is the extent of lymph node involvement? And then has the cancer spread to distant location? Okay. So for most cancers, those are the 3 questions that we ask to tell us the stage. Great. And before starting treatment, all patients should have staging documented in their chart. Okay. So anytime a patient is started on chemo or radiation, we need to know their diagnosis based on pathology. And then we also need to know what is the stage of that cancer. So what is the size of the primary tumor? Are the lymph nodes involved, and is there metastases or not? Any questions about this? All right. All right. And so again, each cancer type has a different way to determine stage, but in general, there are 4 different stages of cancer. So as stage 0 cancer, we call this carcinoma in situ. So this is not cancer, but it might become cancer at a later time. So this is why early detection is important. We're trying to detect stage 0 cancers, maybe in the cervix, maybe in the GI tract, and then eliminate that carcinoma in situ before it develops into cancer. Okay. Stage 1 cancer, this is early stage. So this is a localized cancer. So this might be, again, going back to the melanoma in the epidermis, in that first image where the cancer cells are just confined to the epidermis, that would be an early stage or a stage 1 cancer. And then stage 2 and 3, there's some spread to the nearby tissues or nearby lymph nodes. So again, using the example of the melanoma, when that melanoma started to invade the basal layer, the dermal layer, that we would consider that to be stage 2 or stage 3. And then finally, what is stage 4? I hear some whispering. Somebody say it loudly. You know, your whispers are correct. Say it loudly for the whole group to hear. Yeah, other organs. Yeah, exactly. What do we call that? Metastasis, exactly. So stage 4 is a cancer that has metastasized to other parts of the body. Um, I see some of you taking photos. We'll share all of these slides with you. So you can review them yourselves. All right, so this is just an example of a breast cancer patient who initially had a stage 1 cancer. So you can see this, there's just a very small lesion, maybe would be probably a T1. It's very small. The tumor size is very small. So that would be stage 1. And then you can see it over here. The cancer has grown. So this is a large invasive cancer lesion, maybe stage 2. And then this is, then here it has developed into stage, maybe stage 3. You can see the cancer in the breast has grown, and then the cancer has spread along the lymph nodes. In this image, it looks like, from what we can see, only the nearby lymph nodes are involved. So this still might be just a stage 3 cancer. And then there's no photo of stage 4, but stage 4 would be a patient where either the breast cancer has spread maybe from the lymph nodes on the left side of the body, maybe to the right side, maybe to lymph nodes like in the pelvis, or it has spread to distant organs, maybe the liver, maybe the lungs, maybe the brain. Okay. Yes.
When we look to the size of tumor, is this our discussion with waiting to see that this one is maybe T1, T4, or is it just someone's discussion saying outside? Maybe 2 centimeters will be T1, and then someone comes and say 2 centimeters is T10, or specific to the areas.
Yeah, that's a really good question. So there are like international standards for how each cancer is staged. I can show an example later of how that's done, but there are guidelines that say for each type of cancer, they tell you what is T1, what is T2, what is T3. So I don't remember off the top of my head, but T1 for breast cancer might be a tumor that is less than like 5 millimeters. And then T2 might be a tumor that is between 5 to 10 millimeters. T3 might be a tumor that is greater than 10 millimeters. So for every single type of cancer, there are guidelines that describe in a lot of detail what is meant by exactly what is meant by T1, T2. Okay. So it's always the oncologist or the doctor who determines the stage. So they would reference those guidelines to determine what the T, the N, and the M. That kind of sense.
Yes, so millimeters are estimated.
They're not estimated. I mean, sometimes depending on where the tumor is, it might be some estimation, but they try to be as objective as they can. So if it's a palpable mass, measuring, like actually taking a measuring tape and measuring, based on radiology with the ultrasound or CT can also tell us the size of the tumor. Sometimes it has to be an estimate, but they really try to be as objective as. Yes.
You have staging where the patient will just come in and then like for breast cancer, they are just examined by the doctor and to estimate like and then you have an initial stage. You will find that the initial stage is 1 and then they choose CT scan, and then come back and say, maybe take or chemotherapy. So we don't just use one, we can't just look at the examination and say this is the key. You still need to do the evaluation.
Yeah, yeah. So that's why we use all of these tools to help determine the stage. So the physical exam, imaging, blood test, etc., so that we can be as accurate as we can. All right. So another factor that we use to determine the prognosis is the patient's performance status. So this tells us what is the patient's general health status. So ECOG just stands for the group, the organization that created this scale. So it's the Eastern Cooperative Oncology Group. It's not important to memorize, but just so you know where the ECOG comes from. And it is a scale from 0 to 5. And so every patient with cancer, we need to, before they started on treatment, we need to understand what is their performance status. And so a patient with a performance status of 0 all of us in this room, we would have a performance status of 0, okay? We are fully active. We're able to carry out all of our normal activities. We're able to perform our activities of daily living at home. We're able to go to work and perform our job normally. And then grade 5 is a patient that is dead. And then grade 4 is a patient that is completely disabled. They're not able to carry out any self-care, any of their activities of daily living, and they're totally confined to the bed or to the chair. And then we have grade 1, 2, and 3 in between, okay? So a patient with a lower grade performance status compared to a higher grade performance status, who do you think would have a better prognosis? Maybe let's compare a patient with ECOG of 1 compared to a patient of an ECOG with 3 or 4. Who has better prognosis, most likely? Grade 1, yeah, exactly. And this is really important to understand as well, because patients with a higher performance status usually respond poorly to therapy. They don't tolerate chemotherapy or radiation therapy very well. And so if a patient has a performance status of 3 or 4, usually we will not treat them with chemotherapy or radiation therapy, okay? Because we know the treatment probably will do more harm than good, because they're not going to tolerate it very well. So in most, there are some exceptions to this, but in most cases, we really should only be administering chemotherapy, providing radiation therapy to patients with a performance status of 0, 1, or 2. Does that make sense? Yeah. Okay. So then how do physicians determine the appropriate treatment for a cancer patient? What they do is they take all of those factors that we just discussed on the last slide together to come up with a plan for treatment. So they consider the diagnosis, the stage, and then that gives them clues to what the prognosis might be, and then they can determine what treatment options might be appropriate for the patient. How am I doing for? Yeah, we're almost done. Yeah. Okay. So when we think about for each patient, it's really important to understand what is the goal when we're treating a patient with cancer. is the goal to prevent cancer. So this would be all of us in this room. Likely we don't have cancer right now, but what are the tools, the things we can do to prevent cancer? And then once a patient has developed cancer, we need to understand if the goal is to cure the cancer or to palliate the cancer. Okay. And so if the goal is cure, we are trying to eliminate a cancer that has developed. And then if the goal is palliation, the goal is not to cure the patient, but rather to optimize the patient's life. And for typically in patients with solid cancers, patients with a stage 4 cancer that has metastasized, we know that we cannot cure that cancer. So the goal is rather to palliate and optimize the patient's life. And so we might be able to optimize the patient's life by providing chemotherapy that reduces the tumor burden, or radiation that reduces the tumor burden. So we still might give chemotherapy or radiation, even surgery in some cases, to patients with the goal of palliation, but we're providing those treatments not with a hope of cure, but just to optimize the patient's life. Okay. And then in patients with an earlier stage of cancer, where the goal is cure, we might treat those patients more aggressively with more intense chemotherapy, with more intense radiation therapy, so that we attack the cancer to the best of our ability, hopefully to achieve cure. Okay. And so this is really important to understand. Once a patient has developed cancer, we need to know what is the goal. Is the goal palliation, or is the goal cure? Okay. All right, I won't spend too much time on this because we'll review this in the coming days. But these are generally the 4 treatment modalities for cancer. So surgery, radiation therapy, then we have our systemic therapies. So that includes chemotherapy, hormone therapy, biotherapy, and then palliative care as well. And somebody said one of their hopes for the week was to learn like how this is determined. I think this will become more clear in the upcoming lectures. But depending on the type of cancer and the stage of cancer, we combine different modalities. Okay, so for some patients, they might receive surgery and systemic therapy. For some types of cancers, they might receive surgery and radiotherapy and systemic therapy. Some patients might receive only surgery. Some patients might receive only radiotherapy. Some patients might receive only systemic therapy. Okay, these are all kind of think of them as like tools in our toolbox. And depending on the type of cancer and the stage of cancer, we use a different combination of these tools to treat the cancer. Okay. All right, so we'll talk a bit more about radiotherapy later, so I won't spend too much time on these slides, but in summary, radiation therapy uses high energy X-rays or charged particles to treat cancer. And so when radiation therapy is applied to the cancer cells, it causes damage to the DNA of those cells. And then that damage to the DNA cells prevents it stops that abnormal division, multiplication of cancer cells. Okay. Unfortunately, Radiation therapy also causes damage to healthy cells, but in general, the healthy cells have a better ability to repair and regenerate and recover compared to cancer cells. Okay. And there are certain cancers respond better to radiation therapy. There are some types of cancers that we say are more radiosensitive. Okay, and then there are some cancers that are radio resistant. So even if we apply radiation therapy to those patients, it's not going to do anything to those cells. So osteosarcoma is an example of a radio resistant cancer. And so so we wouldn't provide radiation therapy to a patient that has a radio resistant type of cancer. So that's why when you're going to Bloemfontein, you see a lot of patients with breast cancer receiving radiation therapy because those cells are often very sensitive to radiation, but you're not going to see a patient with osteosarcoma going for radiation therapy because those types of cancer cells are not going to be very sensitive or responsive to radiation. All right, so in general, there are two types of radiation therapy. So external beam radiation therapy is shown in the top photo. So the radiation therapy is applied from this machine, this EBRT machine. That's external to the patient, and then the radiation rays are delivered to the part of the body where there is cancer. So if it is a breast cancer, the radiation therapy is going to be applied directly to that area of the cancer. If the patient has cervical cancer, the external beams are going to be directed towards the pelvis. Okay, and then there's also brachytherapy that is used for some patients. And so this is where rather than an external beam of radiation, the radiation therapy, there's actually radioactive materials that come into direct contact with the tissues that are to be treated. So this is used quite frequently in cervical cancer. So there's radioactive material that's applied directly into the cervical area to treat the cancer. All right. So side effects of radiotherapy. So fatigue is the most common side effect. About 65 to 100% of patients, so the vast majority of patients will experience fatigue. Skin irritation is common, and that the irritation is going to be dependent on where the radiation is delivered. Head and neck. For head and neck cancers that are treated with radiotherapy, these patients might experience dysphagia, dysgeusia, mucositis. When breast cancer, these patients might experience edema, pneumonitis. Thoracic cancers might experience esophagitis, dysphagia, pulmonary or cardiac fibrosis. Pelvic radiotherapy can result in dysuria, diarrhea, sexual dysfunction or infertility. And then radiation that's applied to the GI or abdomen might result in nausea and vomiting, diarrhea, weight loss, or poor digestion. So when you think about the side effects of therapy, just think about where that radiation is delivered, and that's where you're going to see the side effects. All right. So quickly, just to review kind of the differences, some of the major differences between pediatric and adult cancers. So in pediatric cancers, these are rarely caused by environmental or lifestyle factors like smoking, HPV, and hepatitis B. Usually we don't know the cause of these cancers. There's no risk factors that we can attribute to the development of these cancers. They're more random. And generally, these cancers are more curable. So in high-income countries, the 5-year survival rate for all pediatric cancers is about 85 to 90%. So most pediatric cancers, if patients have access to treatment, to the best practice treatment, they will achieve cure. And then adult cancers are more often caused by environmental or lifestyle factors. And typically they're less curable, and particularly when in advanced stage. So as I mentioned earlier, adult cancers with a stage 4, disease typically are not curable. Sometimes in pediatric cancers, even if a patient has a high stage 3, stage 4, we might still be able to cure that cancer. Any questions about this? Any questions from our pediatric nurse? No. All right. And then we also need to, so there's also cancers can be divided into 2 different groups, solid cancers and hematologic cancers. So hematologic cancers are cancers of the blood and the lymphatic system, and these can be treated with systemic therapy, so chemotherapy, most often without surgery. And an advanced stage hematologic cancer is often curable, even with only systemic therapy. So an example of this is a leukemia. So in pediatrics, acute lymphoblastic leukemia is really common. Patients with a really advanced acute lymphoblastic leukemia can be cured with just chemotherapy. And then if we compare that to solid tumors, so this is a growth or a tumor that arises from an organ. So this would be a breast cancer, a lung cancer. And these are only curable when detected early, and treatment usually includes surgery. So we need to remove that tumor or that growth in order to achieve cure, typically for solid tumors. And then again, advanced stage solid tumors are mostly not curable. Okay. All right. And just quickly, I think you all know that Sankatana Oncology Clinic is providing chemotherapy to a lot of patients. But there's no radiation therapy that's provided in the country currently. All patients that require radiation therapy are sent to Bloemfontein to receive that. And so because of that, we're not able to treat all cancers yet in Lesotho. But these are the cancers that we have started to treat in Lesotho with the chemotherapy that we have available at Sankatana. So breast cancer, cervical cancer, chronic myeloid leukemia, colon cancer, gestational trophoblastic neoplasia, Hodgkin's lymphoma, non-Hodgkin's lymphoma, Kaposi sarcoma, ovarian, and prostate cancer. Okay, so there are some other cancers here and there that we have been able to treat, but these are the most common cancers that we have been treating. All right, so just quickly in summary, cancer represents a significant burden of disease all around the world, including Lesotho. Prognosis is influenced by many factors, including the type of cancer, the stage of cancer, and the patient's performance status. Accurate diagnosis, which should typically include pathology, is critical to determining the appropriate treatment. And then there are three major treatment approaches for cancer, which we'll describe in more detail in the upcoming lectures. And they include chemotherapy, surgery, and radiotherapy. And then there are notable differences between pediatric and adult cancers, and liquid versus solid cancers. Any questions? No, this is a lot of.
It's not a custom research, but I've learned that patients who are going for herniation,
Mhm.
they are saying they are being told not to wash, to bathe themselves.
Okay.
Probably if there's in the on the test
Mhm.
this side and on that side. So why?
Yeah, so it's because of one of the side effects we talked about, if you remember, is skin irritation. So the skin becomes very sensitive after radiation. And so if the concern is that if the patient is rubbing, washing the skin, that it can cause damage to the skin because it is sensitive after radiation. Anything else? This is not my area of expertise.
Also,
You guys do
so-
this.
So, but also with
Yeah.
soap, because those soaps will cause more irritation to the skin. Moisturizers, like lotion, that's also not recommended for patients with radiation because those cause, like the chemicals in there may cause more irritation to the skin. So yeah, that's.
Yeah.
It's like I give it, proven thing, yeah. But basically, like they're saying, while we're giving treatment, we wouldn't want any other clinical stop treatment, right? So if, say, perhaps, they were to try a bath, and then, like she said, there's use of soap, and then there's irritation, or there's use of force, and then this becomes an opening to the skin, that means that area has to heal first, such that treatment can continue. So to avoid all those things that are not told,